Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers. I am your host, Amanda Mixon, and we are coming to you today live from our 6th annual conference in Denver, Colorado. We are in my backyard, which has been awesome. Today, we are going to talk about a complex and important topic, ANCA-Associated Vasculitis. Joining me is an expert in the field, Naomi Amudala, who's a nurse practitioner at Penn, and she's going to help us unpack the latest insights, challenges, and real-world considerations in caring for patients with this condition. So let's go ahead and dive right in. Thank you so much for being here, Naomi. Obviously, such a close friend of mine, a board member, and really the expert in ANCA-associated vasculitis.
Thanks for having me.
Okay, so for listeners who might be newer to the topic, can you start by giving us a quick overview of what ANCA-associated vasculitis is and how it typically presents in patients?
Oh, sure. Quick will be the challenge, but I'll do my best. So taking a step back, vasculitis is a chronic autoimmune inflammatory disease that affects blood vessels. That's a very basic level. There's over 30 different types of vasculitis, and it's classified based on the size of the blood vessel it affects. So for ANCA-associated vasculitis, that affects primarily medium and small blood vessels. So if you think about where do we have medium and small blood vessels, that's where you could potentially get vasculitic involvement. I think it's confusing sometimes the way we name diseases. So why is it ANCA-associated? What does that mean? So there is an ANCA antibody that is associated with this type of vasculitis. And I want to be clear that you can have a negative ANCA and still have the disease, but the majority of patients will have a positive ANCA. And there are 3 different types of diseases that are kind of fall under this ANCA-associated vasculitis umbrella, and that's granulomatosis with polyangiitis, GPA, microscopic polyangiitis, MPA, and eosinophilic granulomatosis with polyangiitis, EGPA. We just like to use lots of letters and words that nobody can really pronounce. And so that grouping of those 3 diseases, that falls under ANCA-associated vasculitis, but then we have kind of 3 distinct disease states. All 3 of those diseases, there's a lot of overlap, but they are kind of separate and they do kind of behave differently. So hopefully that wasn't too long of an answer.
No, I think it's interesting because you always make it seem so simple. But obviously, as you know, it's a really challenging diagnosis. It's obviously can be life-threatening for our patients. So it's one of those things that we certainly do not want to miss in a patient because obviously that could lead to some very, very terrible consequences. What do you see as the biggest challenge for providers when it comes to diagnosing ANCA-associated vasculitis? I know we want to do it early and accurately.
Yeah, so first of all, these are rare diseases. These are really rare diseases. So it's not on the forefront of your mind when you're seeing a patient come in. And then as anybody says who sees vasculitis, if you've seen one vasculitis patient, you've seen one vasculitis patient. Everybody presents differently. And so that can also make it very challenging. I do want to call out, I think asked me in the previous question, what were some signs and symptoms? And just a few kind of high levels. So if somebody comes in with a history of chronic sinusitis, that is probably something that you should work up. And so we're talking multiple sinus infections throughout a year, doesn't improve with antibiotics, really profound nasal crusting and bleeding and beyond kind of the normal stuffy nose. Sometimes you can even have an erosion of your nasal septum, so you get a saddle nose deformity. 100% that needs to be worked up. You need to get a sinus CT scan. Other big ones is that 60% of patients often will have renal involvement. So how do you know? Well, you're looking at the urine. You're looking for new protein, new blood, a rise rise in the creatinine, those are all signs that something's not right. And so at the very least, you want to get them to a nephrologist so that they can do a biopsy. ANCA-Associated Vasculitis can do a lot of other things. It can affect the lungs. Patients can get diffuse alveolar hemorrhage. You can get rashes, joint pain, neuropathy, mononeuritis multiplex, hearing loss. You can get retroorbital pseudotumors. It's really head to toe. So I don't want to overwhelm people, but what I would say is you really have to do a good history and reassess patients from head to toe. And if there's anything that doesn't fit with whatever diagnosis they currently have, just think about that diagnosis of vasculitis.
Absolutely. And, I think one thing that you always help me with, because as you know, I do call you a lot when I have a challenging case, it's the biopsies can be really helpful, right? I mean, really trying to get that tissue to really confirm your diagnosis, right?
Yes. Thank you for reminding me. You're absolutely right about that. So that is the gold standard. That being said, if you suspect vasculitis and you have a reasonable suspicion for it, you shouldn't postpone treatment while you're waiting to get that biopsy. And there's different sites that are higher yield. So like a nasal biopsy, you're probably not going to get much. Kidney biopsy, lung biopsy, skin's a nice one because it's not so invasive. We have lots of it and it's easily accessible. So that is another one that's very helpful sometimes in making a diagnosis.
I often think of vasculitis, and I think patients mostly have really high inflammatory markers. Is that true?
Nope. If you've seen one, you've seen one. I would say sometimes yes, but sometimes no. And that's the thing. And that's what my mentor always taught me is you treat the patient in front of you. You don't treat the labs. You treat what you're seeing in front of you.
So challenging, and I think, again, I think it just needs to be on our differential, and it needs to be something at least at the forefront of our minds. If somebody, it's just not making sense, or again, to your point, they have recurrent sinusitis, bloody crusting, obviously to your point, the elevated renal functions, and it's just not making sense. We have to be thinking about this in our field because definitely, I tell people there's very few rheumatologic emergencies, but obviously vasculitis is one of them, but now let's kind of shift a little bit and talk about treatment, which in my opinion also seems to be kind of challenging as well. So can you kind of talk a little bit about the current standard of treatment for patients with ANCA-associated vasculitis that really has evolved over the past few years?
It's amazing. So back in the 70s, when this disease was kind of first discovered, actually, Dr. Fauci was one of the people who was really instrumental in treating this at the NIH, and they used to give massive doses of cyclophosphamide because that was the only medication we had. And since then, we now have 2 FDA-approved medications for GPA and MPA specifically, which is amazing. And that's actually happened within the lifetime of my career. So that gives you a sense of how quickly things have shifted really over the past 15 years. So standard of therapy, unfortunately, always involves prednisone. Induction therapy is what we call the therapy that we use to get people into remission. Usually cyclophosphamide or rituximab. I think now we're shifting away from using cyclophosphamide and primarily using rituximab. We usually give an induction dose of 1,000 milligrams 2 weeks apart, and then try to steadily taper the prednisone. And then the decision of whether or not to repeat rituximab, it's a bit more nuanced, and there are really great guidelines. I do want to call that out. So the ACR 2021 guidelines are very helpful in those decision points of how to treat this disease.
Dr. Merkel yesterday was talking a little bit about how hard it is to not treat. And, I think that is something that we at least need to consider is, not maybe throwing the kitchen sink at somebody if maybe they don't need that. So again, that even makes this more challenging. But I just thought that was really interesting when he talked about that. Sometimes you just have to watch and see, which can also be hard.
Right.
Let's talk just a tiny bit about Avacopan because that's this exciting new addition to the landscape. Where are you seeing it fit? Talk a little bit more about that.
Right. So I should say rituximab was the first FDA-approved drug for GPA and MPA, and Avacopan has the distinction of being the second ever FDA-approved drug, which it can't underscore or tell you how important that is, because it's huge. It's instrumental. It's very helpful in getting the drug for our patients. These are really sick patients who need these medications quickly. And so not fighting with insurance companies for days and days on end and having a labeled indication it's that in itself is literally life-saving. So Avacopan is a C5a receptor inhibitor. So it's a new mechanism of action that we haven't used before. It's used for severe active disease. So that's really important to use it as prescribed. It's severe, it's active. The way it was used in the trial was that it was given in conjunction with standard of therapy care. So everybody in the study got either cyclophosphamide or rituximab plus Avacopan or placebo, and it was a complicated study design. And then they also tapered the prednisone, which they're doing now in more trials, much more quickly than we typically do in the real world. And what you'll see from the primary outcomes is that patients did well. So they were able to tolerate that rapid prednisone taper. And I think that was because they were on Avacopan. So I wouldn't follow that rapid taper unless your patient was on Avacopan. So it's 30 milligrams twice daily. And there are a few different contraindications for it, which you can look at the labeling to review. And generally, my patients tolerate it well. They do sometimes complain of some nausea, headache, but doing that and then giving them that medication, which allows them to taper prednisone much more quickly, it's really been life-changing for my patients.
Absolutely. And, how amazing to get people off steroids sooner. Mm-hmm. I also, again, I keep shouting out your, attending Dr. Merkel, but, no one causes more, osteoporosis than we do, in rheumatology because of the steroids. They're life-saving medications, but there are risks, and we have to think about that with our patients. And so trying to get them off the steroids as soon as we can safely, I think is really important. We all need to be thinking about that. Now, I'd be remiss if we didn't talk a little bit about the conference because we are here at our annual conference. Has there been any sessions that have really stood out to you thus far in terms of great content, et cetera?
Yeah, it's interesting. When we first started this in my first conference, I think there was one session on vasculitis, and that was from me. This year, I was looking at we have sessions on giant cell arteritis. We have Behçet's. We have ANCA-Associated Vasculitis. I think this is fantastic. We are kind of moving away from the bread and butter rheumatology, and we're really presenting our APPs with challenging rare diseases, which they're rare, but they're going to be seen. And so I think that it's really exciting to kind of see people step into their own and presenting this material. And it's all great.
I totally agree. And I think it just speaks to the evolution of RhAPP and the evolution of APPs in this space, that we are seeing these complicated conditions, these complex processes. We're managing these patients, and I think doing a really, really good job. I'm going to ask one more question because obviously this is about vasculitis, but if there's any just red flags that you think we should really know as an APP practicing rheumatology so that we don't miss vasculitis, what are they?
Vasculitis emergencies, diffuse alveolar hemorrhage, so coughing up blood. That's always bad. Go to the emergency room right away. A sudden drop in the hemoglobin. That blood's going somewhere. You need to find out where. I think that's also probably warrants a trip to the ER. A sudden spike in the creatinine. They could be going into renal failure, and we have a very small window to try to regain renal function. So kidneys and lungs.
One last question, Naomi. So obviously, we've covered an awful lot and this in this short period of time, and there's so much more that we need to understand. So come to the RhAPP conference if you've not been, because I think you will gain an incredible amount of knowledge on vasculitis. But if you want to stay up to date, are there other resources, or what do you think the best tools are that you use in a vasculitis center?
Yeah, I think RhAPP does a great job of keeping people up to date between conferences. We're always doing podcasts and webinars and different things like that. And so that's great to stay plugged in. ACR is obviously a wealth of knowledge there. there. And that's very kind of cutting edge, the newest research, which is exciting. RheumNow comes out with interesting things. Sometimes I just look at PubMed and kind of type in, ANCA-Associated Vasculitis, and then see what all the newest papers are that come out. So, utilizing any of those are really useful.
Well, I think having you as one of our board members has really shed some more light on vasculitis, because you're out there doing it. Like, you're seeing these super sick patients every day. And I think it helps our members gain confidence and know that they have the ability to help manage these patients too. Of course, maybe a lot of them are with their, attendees and in a collaborative setting, but we can absolutely manage these challenging patients. So obviously the education you provide to us is so impactful to me personally, because as you know, I'm texting you all the time saying, I've got this patient, what should I do? And you make me look really smart. So I really do appreciate that.
I should say, I think the best advice I ever got from my attending is know what you don't know and know when to ask for help. And because safety first, you want to keep your patients safe. And so I think those are the two best things to keep in mind.
I think we all have this spidey sense where you just know if somebody's sick, and if you need to ask a question. I think APPs are really, really good at this. And so I couldn't agree more. And, as you know, I'm asking you questions all the time. What an amazing conversation, and again, an even more incredible conference that I know we both are so, so proud of. The education here at the RhAPP National Conference has been top-notch. The engagement has been inspiring, and the energy every conference is truly unmatched. A huge thank you to you, Naomi, for sharing your expertise on ANCA-Associated Vasculitis, and to all of you that have joined us in this special episode. Mark your calendars now, please, because our 2026 RhAPP National Conference is heading to Las Vegas, Nevada. So that should be really, really fun. You'll not want to miss this chance to experience this community, the education, and of course, the excitement all over again in a city that is really built for high energy. I'm Amanda Mixon. Thank you again for tuning in, and we can't wait to see you in Las Vegas.